Hi, my name is Barack Gasser. I'm a primary care doctor and professor of medicine at the University of Washington. I've been a primary care doctor here for many years, but for the past 5 years, I've been studying dementia and thinking about how can we make this a more efficient and practical and more effective way of treating this really difficult disease in primary care. So I've developed a series of video segments that goes through how we can do a better job of diagnosing dementia, evaluating it, managing it, and really helping to do a better job of planning for it in the primary care setting. We're going to start out first with an introduction to dementia in the primary care setting. So what makes this disease so hard? And I want you to take a moment to just stop and think back on patients with dementia that you've had and just what has made this disease so difficult in your practice. Because there really is just no doubt that for just so many reasons, this really is one of the most challenging things that we deal with in primary care. And I think at the heart, it's so hard when people just slowly lose the very kind of like center core of who they think of as who they are as their cognition slowly fades away. It's also so common, maybe 80% of people with dementia will at some point go through this really difficult segment of the disease where they become really agitated, and that can become really frightening for caregivers, really hard for primary care to manage, hard for anybody to manage that agitation and paranoia that can so commonly occur. And there's just so much stigma with this disease. People are so afraid and ashamed of it that they don't want to talk about it. It sort of makes it easy for us to not talk about it. It's just so easy to sweep it under the rug and pretend it's not happening, which just makes it harder to sort of bring it out of the shadows and really start to do a better job of identifying it and really sort of managing it. And there is just that whole period of time early on in the course of the disease where it's unsure what the diagnosis is. Is somebody truly developing dementia or not? And that uncertainty can be so difficult. And then there's just the elephant in the room, which is that we don't have a disease-modifying treatment for dementia. And so it can get easy to think of like, oh, why do I want to open this can of worms to really start thinking about and talking about dementia if there's nothing that we can, quote unquote, do about it. But I really want to make the case for just how much we actually can do to improve dementia care by making that earlier diagnosis. And this is so much at its center, aligning the care that people get with this big giant thing that's happening to them. So maybe the most important organ in their body, their brain, is slowly failing. And when we don't take that into account with the rest of their holistic primary care, we're not able to really provide good care. And that comes out as we think about what preventive measures to be using, like healthcare maintenance things, how to communicate with patients and their families, and just the whole general process of decision making that we go through with all the other medical problems that people generally have. That there's just so much value to using the dementia as an organizing principle for that care, which we can't do if we don't make a diagnosis. And really what I think of as the most valuable reason to make an early diagnosis of dementia is really to bring the family into sort of that care relationship. So, I mean, one of the things that I love the most about primary care is how you can really develop that one-on-one relationship with a patient over many, many years, which is so meaningful and so great. What's tricky is as somebody develops dementia, it becomes so important for them to have the connection and the connection and support of their families that it really doesn't work very well from a primary care perspective to just stick to that one-on-one relationship with a patient. And so you really do need to bring the family members in terms of communication and support and understanding. And you can't do that without making an early diagnosis. One of the last segments that we're going to talk about in this series is advanced care planning. And really the most important part of advanced care planning is identifying who somebody's durable power of attorney is with alternates. So often it is less crucial that we have somebody fill out a durable power of attorney form because the person who legally would default as their durable power of attorney is often their spouse. And it's, you know, if we don't have a durable power of attorney form filled out and they lose the capacity to make decisions for themselves, then having the legal default be their spouse is fine. And it doesn't matter that much to have that form filled out. The issue with dementia is that this is a 10 to 20 year time horizon for their disease. And during many of those years, the odds are high that they're going to lose the capacity to fill out a form like that. And the odds are also pretty high that over the course of that 10 to 20 years, their spouse may no longer be either around or have capacity to be their proxy decision maker. And so identifying early in the course of dementia, while somebody is still able to fill that form out, to identify who the alternates would be to their sort of legal default is just so important. And so having the opportunity after an early diagnosis of dementia to have somebody fill out a durable power of attorney form is just so important later. And then there's a whole series of patient safety issues that we really can do a better job of identifying and addressing better if we identify dementia earlier in its course. So these are really the four main topics that we're going to cover through this series. We're going to start out thinking about how to make a diagnosis of dementia in a primary care setting, really drilling down to really what is often the most sort of psychologically fraught part of managing early dementia, which is a safe retirement from driving. We're going to really tackle what I was saying before about that really, really hard treatment of behavioral symptoms. And then we're going to end with really what I think of as the golden key, which is how to do a better job of advanced care planning for dementia. We all know just how common dementia is. This is a giant problem in the United States. More than 5 million Americans are currently living with dementia. It's 1 out of 10 people over age 65. It's really about a third of people over age 85. And really, if we think about how hard dementia is now, how big a part of our practice it is now, it's pretty intense to think about what the epidemiological forecasts are for the coming years, where there are really solid projections that the number of people living with dementia is going to go up by 40% in the next 10 years. And then in the coming years after that, may even triple. And every time I say that statistic, I really am just so struck by sort of what a crazy number that is. How can those numbers triple? Where is that coming from? And there's really two things going on at the same time. Number one, people are living longer than they ever have before. We're doing a better job of treating their cancer, treating their heart disease. More and more people are living into their 70s and 80s than ever before. And there's this really weird quirk in our society, the demographic quirk of the baby boom bubble. And this is really something that happened in the 20 years after World War II, where there was this giant spike in the number of people born in the United States between 1945 and 1965. And that cohort of people, that baby boom bubble, has persisted as a group of people. That is, there are many of them. I am one of them. And the very oldest of the baby boom generation is just now turning age 70. And so this is where they are today, the baby boom bubble, the very sort of the leading edge of the baby boom bubble is just entering the age at which people become at high risk of developing Alzheimer's disease and other forms of dementia. And so if you follow that bubble through 12 years from now, you can see how not only are they going to be living longer, but there are just going to be a lot more of them. And that's really where this like silver tsunami projection comes from, of really the number of people living with dementia tripling. And so if we think it's hard now, it's going to be much harder down the road, and we better start getting a handle on how to deal with this disease better in primary care. So, I mean, you can really make a good case for this being the number one challenge that we face in primary care. And this is so much a primary care disease that there are other really high impact diseases where it's relatively easy to just refer somebody to a specialist and have them take over the management of that complex and difficult disease. So if somebody has lung cancer, it's pretty easy to refer them to a lung cancer specialist, and that lung cancer specialist will then most of the time really sort of take over the management of that disease. But there simply aren't enough neurologists out there, not enough dementia experts out there to evaluate and manage long-term the number of people with dementia. And it's especially that day-to-day long-term management that is really beyond the capacity of the dementia expert community, that really we as primary care doctors really can and should be able to do a good job of dealing with it from a chronic disease management point of view. That's what we do best. We can do this. And it's really so much what patients want. People want to stick with the primary care provider who, ideally they have developed a good relationship with over 5, 10, even 15 or 20 years, somebody who they really know and trust and who they want to stick with as the person who's primarily managing their dementia. And with good training, with good, efficient, focused training, we really can do a good job with this disease. And so I want to introduce a case that we'll be following through this series. An 82-year-old man who is in your office for a wellness visit. He's generally very healthy. He has hypertension and osteoarthritis. He takes losartan for his blood pressure, occasionally takes some ibuprofen, and occasionally does take some Ambien to help him sleep. And during the course of that annual wellness visit, he does mention to you that he's been worried about his memory. And so what should you do? So the tempting thing to do, and something that I do believe does happen and that I have been guilty of myself in the past, is to sort of brush away a concern like that and say, oh, don't worry, I'm struggling with my own memory as well compared to where I was when I was in my 30s. It is normal, and this is a normal part of aging, don't worry. B, you could right then and there just fire off a referral to a memory care clinic. C, you could stop everything and do a 15-minute cognitive assessment right there, but then find yourself really far behind in your schedule. Or D, really what I'm going to make the case for here is really stop and say, that could be worrisome, but I could help. Let's schedule you for a memory evaluation visit that's going to be a longer follow-up visit. And so importantly, I want to make sure that you bring a family member to that visit, because we're not really going to be able to adequately assess your cognition just one-on-one. We really need to have someone from your family there with us to help. We can do this. Let's schedule that visit for you. And so that's going to be the next segment in this series, which is how to do a follow-up visit for cognitive concerns, really with the focus being efficient and effective primary care evaluation that we can do, we should do. And so thank you for listening to this first segment. This is really all about how to talk about dementia in the primary care setting. My email address is there as we go along in this series. I'm always going to be open to questions. Feel free to email me, and thank you for listening.